So we'll move to the next talk by Professor Wendy Stock. I have already introduced Dr. Wendy, who were off the platform. So Dr. Wendy will be talking about the current trends and advances in the frontline management of acute lymphoblastic leukemia. So we'll have your slides up by the team.
Thank you very much.
And then we can start.
Thank you so much. Can you hear me now?
Yes, I can hear you.
Okay. Thank you so much. I'm so sorry about my technical incompetence. And thank you all so much for inviting me. I hope I'm a better doctor than I am a slide operator. Today is my pleasure to speak to you about the changing dynamic in treatment of ALL. And I so appreciate Nicola's beautiful talk just before mine, so that it will kind of complement, I hope, what I'm going to be saying. These are my disclosures. This is the summary slide showing you overall outcome in the past decades for adults with acute lymphoblastic leukemia in the United States cooperative groups. And what I wanted to highlight here was that we are moving forward. You will see in the next few slides how these survival rates, I hope, are going to really improve in the next several years and have already improved quite a lot. One of the ways that things have gotten so much better are the intensification approaches that we've used in the young adult population, sort of adapting more faithfully the treatment that is used in the pediatric population. And the adoption of these pediatric regimens faithfully with high doses of and frequent dosing of asparaginase, glucocorticoids, vincristine, and intrathecal therapy have been a key to the improvement in survival for our young adults with acute lymphoblastic leukemia. We have found that these regimens are feasible, that they are associated with low treatment-related mortality, but the toxicities are still significant, and they do increase with age. While they are manageable, they're still a significant problem, and that's something that we're working on. The major improvements have been made, however, in event-free and overall survival compared to historical controls, and now routinely reach more than 70%. This has really become a new standard of care for our younger adults with acute lymphoblastic leukemia. And I will show you on the next slide some of these results. This is a risk-adapted approach that was taken by the NOPFO group a number of years ago. This is a beautiful study that was published looking at an identical treatment regimen that is stratified by treatment response, not by age, and resulted in outstanding survival, as you can see here, for all adults and children who were enrolled on this trial. And this, again, was the identical treatment regimen given to all patients. The treatment was a little bit different based on basically minimal residual disease, suggesting treatment sensitivity after induction. This slide shows our data from the Cancer and Leukemia Group B, showing our change in outcome when we faithfully replicated an intensive pediatric regimen for patients ages 16 to 39 years. And compared to our historical controls, where our survival for these patients was only 46%, we now have overall survival rates, again, of greater than 70%, 73%. And this replicates what was found by the pediatricians in a younger patient population many years ago. So we are moving forward in our treatment for young adults with ALL. And as Dr. Gokbajit just beautifully outlined, minimal residual disease eradication should be our goal. And here are our data showing that disease-free survival, when you achieve MRD negativity after only induction therapy, is outstanding. 85% disease-free survival with no late relapses compared to those patients who remain MRD positive, whose outcomes are not as good. And now, as shown to you by Dr. Gokbuje, we have strategies where we are now employing new agents to try to eradicate minimal residual disease early and prevent relapse and emergence of resistant clones. Unfortunately, it's a challenge because only 40% of our patients are in this category at the moment after induction therapy. So we have to get the majority of patients here into this category. And how are we going to do it? Well, I just told you that further intensification using agents that we already employ is probably not going to be feasible. And you can see here on this slide in a recently published manuscript from Dr. Advani and colleagues reporting on outcomes for patients on the CALGB 10403 regimen. You can see that the different toxicities that are associated, for example, with asparaginase in particular, become higher even within the 16 to 39 year age group as one ages. And so further intensification is probably not the way to go because these toxicities are significant and impair our ability to move forward in a unified fashion with these patients. So how are we going to move forward? Well, Dr. Gokbuje already gave you a beautiful presentation on how this is going to be possible. And one of the ways we're focusing are on the use of the new antibodies in treatment. Dr. Gokbuje already went over some of this data. This is the TOWER study that resulted in approval of Blinatumomab in the relapse setting for adults with ALL. And you already know these results. I'm going to just move on to this slide, showing that even in the relapse setting, as Dr. Gokbuje already showed you, the response rates were quite good and much better than anything that we've had in the past. This is in comparison to standard of care. And these are the true CR rates here. Oh, I'm sorry about that.
Yeah, I hear you now.
Okay, apologize. I apologize for that. I must have clicked it. Again, my technical expertise is lacking. This is the Inotuzumab study that resulted in approval of Inotuzumab for patients with relapse disease. And again, very similar to the TOWER study compared to standard of care therapy in the relapse setting, and resulted in extraordinarily, I'm not able to advance my slide now. Could you advance the slide for me?
Mr. Ayman? Anyone from the technical?
Here, perhaps. Oh, there, I got it now. I'm sorry. Excuse me. Don't know what happened there either. But you can see here that, again, extraordinarily high response rates and, importantly, high MRD negativity rates have been achieved in the relapse setting. So this brings us to the idea, as Dr. Gokbuje already showed you, that we can use these novel antibodies, which are quite well tolerated, in perhaps the frontline setting to achieve early eradication of minimal residual disease and improve event-free and overall survival. And these agents are now being built into frontline therapy, as already showed to you. In the United States, the trial that we're doing in the young adult population to try to achieve even improved outcomes is this trial, AO41501, including, again, younger adults with ALL up to the age of 40 years. And again, it is really a study that takes the 10403 regimen and expands it to include the addition in a randomized fashion of Inotuzumab Ozogamycin to try to achieve that early eradication of minimal residual disease and improve event-free survival. And our goal is to improve event-free survival from 66 to 80%. The trial has already accrued more than 50% of patients, so we're hoping that within the next year and a half or so, the trial will be fully accrued and we will begin eventually to see some results. What I can tell you is that this addition of Inotuzumab to frontline therapy has been very, very well tolerated. And here's another schema showing you this regimen again with the addition of Inotuzumab in the front line in a randomized fashion. Now, I already showed you that there is toxicity when we try to use these pediatric regimens, even in the older, younger adults. And there have been a number of studies to try to determine what the age limitations are to this intensive pediatric approach. This is a publication from the French group that shows you really that once you reach around age 50, the exact replication of these pediatric regimens with these high doses and frequent doses of asparaginase, high doses of glucocorticoids, et cetera, is probably not tolerable. And this is due to increasing toxicity. So what are we going to do in our older adult population? And this is the population, I think, where we really are bold enough to make some significant advances because of the poor outcomes that we have previously experienced in our older adults with ALL. Just to go back to that early slide that I showed you, these were the very poor outcomes of adults with ALL over the age of 60 on CALGB studies over the past number of decades. And so this is the group where all of us are trying to make bigger changes and be a little more bold in changing our regimens. One of the leaders in this change has been shown to you by the MD Anderson group, where they use the Inotuzumab Ozogamycin to replace the very high intensity chemotherapy regimen of Hyper-CVD that they have used for many decades at MD Anderson. And in this case, they took away the very intensive therapy, removed the anthracycline altogether, and added instead Inotuzumab. The median age of this population was 68 years. You've seen these data published already. But what it shows you is that the CR rates in the frontline setting now with Inotuzumab and very low dose chemotherapy are extremely high, and the median progression-free survival much better than what I showed you on the previous slide, suggesting that perhaps by adding these novel agents in the frontline with reduced dose intensity chemotherapy, we can achieve very respectable results. We're even getting more bold in the sense of moving away from much chemotherapy at all. This is a trial that was done and led by the Southwest Oncology Group by Dr. Anjali Advani. Update was presented this year at ASH, but it shows that one could use in older adults, and you can see here the starting age was 65 years and above, was really driven by use of Blinatumomab only with dexamethasone and IT chemotherapy. So other than the steroid free regimen, just Blinatumomab induction with dex and IT chemo, Blinatumomab consolidation with IT chemo, and then some low-dose chemotherapy comes in with POMP maintenance. In this case, the median age was 75 years, and many of the patients were relatively more frail. There were no deaths during the first 28 days. The treatment was well tolerated. There was minimal neurotoxicity, which was a concern with the Blinatumomab in the front line, especially in an older adult population. And the CR rate was 66%. The median survival was still short at 1.3 years, but overall survival quite good at 1 year. And this gave us an encouraging basis to move forward. So currently in the US, in the National Cancer Trials Network, we are now doing a study that incorporates both agents that I mentioned, Inotuzumab and Blinatumomab, and it's really a chemotherapy-free regimen for adults over the age of 60 years. And we are accruing actively on this trial. So we've gone from the intensive approaches to a modulated approach using both antibody therapy and chemotherapy to now a totally chemotherapy-free regimen for our older adult population, and we will hopefully see good results. This trial, again, is more than 50% accrued, but we don't have much data. I can tell you from my own experience that it is a quite well-tolerated regimen with nice response rates so far. Dr. Gokbajit already showed you this beautiful paper that was just recently published showing the same approach in Ph+-positive ALL, where we're now incorporating the Blinatumomab into frontline therapy. This is the Italian study that was just published, and Dr. Gokbajit just showed you the lovely results of being able to use Dasatinib, a targeted kinase inhibitor, with Blinatumomab and IT chemotherapy in the frontline setting. Very similar approach to the non-Ph positive ALL that I just showed you from Dr. Advani's study. And again, this is a fully published manuscript now. You saw the schema in the previous talk, so I won't belabor it, but basically, again, just Dasatinib, Blinatumomab, no additional chemotherapy other than intrathecal therapy. And the endpoint of the study was MRD response after 2 cycles of Blinatumomab. And you can see the results here. MRD response of 60, negative response of 60%. And the outstanding overall and disease-free survival, with a number of patients in this study still undergoing allogeneic transplant in first remission, but not all patients undergoing allogeneic transplant in first remission. So again, the concept of moving away from the regimens that have caused a lot of toxicity in our older adult population by incorporating these novel and very, very effective targeted antibody strategies. What about T-ALL? T-ALL remains a bit of a bigger challenge since we have not yet developed antibodies to T-cell antigens that have been able to be faithfully used in the actual clinical setting. There are a number of strategies going on now that may be able to enhance response in patients with T-ALL. One of the things that has been shown is that we know that patients with T-ALL in the standard treatment approaches do just as well now as patients with B-ALL, and in some cases even better. These are our results from the 10403 trial, showing you that T-ALL patients do well, but as I showed you on the previous slide at the very beginning, MRD positivity in this group is also very predictive of outcome, and therefore it would be nice to have agents that we could use to eradicate MRD in patients with T-ALL. As I mentioned, we don't yet have these antibodies in the frontline therapy. There are some strategies that are being developed now, but we don't have those. What we do have is Nelarabine, which has been a drug that's been approved for relapsed T-ALL for a long period of time. And a number of years ago, the pediatric group in the United States, the Children's Oncology Group, did a study where they did a very similar thing to what we're doing now with the antibodies, where they added Nelarabine as a module of treatment in several time points during frontline pediatric intensified therapy for patients with T-ALL. So in essentially taking a pediatric regimen and interspersing, excuse me, a number of cycles of Nelarabine into the frontline setting. And when they did that, they found an outstanding 4-year disease-free survival of about 89% when Nelarabine was added to the frontline treatment. These are patients ages 2 to 30 years, so a younger patient population, but including some young adults with ALL. So interestingly, the addition of Nelarabine is important for even the higher risk subsets of T-ALL, including the early T precursor ALL patients, which previously, as I'm going to show you here on the right, have done very, very poorly. In this study, with the addition of Nelarabine in this pediatric, largely pediatric group of patients, the addition of Nelarabine resulted in equally good outcomes for these early T precursor ALL patients. So it is very encouraging that this might be at least a very good approach with a drug that we currently have in our armamentarium to move forward with patients, for patients with T-ALL. So in conclusion, the adoption of pediatric regimens in young adults with ALL has improved survival rates, but toxicity limits expansion into older adult populations, and new targeted antibodies in the frontline therapy for B-ALL are being tested to improve event-free and overall survival with the goal of early eradication of minimal residual disease with the hope of having minimal toxicity. And Nelarabine in the T-ALL patients has been shown, at least in the pediatric population and young adult population, to improve event-free and overall survival. We can now move, as you've seen here on these slides, to minimize and potentially, we don't know that yet, eliminate much chemotherapy by incorporating these antibodies into frontline therapy of older adults, where we've really been able to be more bold because of the poor outcomes with our traditional approaches. And as you saw from both my quick slide there and Dr. Gokbaje's presentation, that patients with Ph-positive ALL and trials in that setting have really already led the way in this department. Is the future of ALL therapeutics chemotherapy free? Well, we don't know. The wisdom of the older adult studies or older adults will inform our approach to the younger patients. And there are other exciting targets for patients, especially with T-ALL, where we don't have such important and useful antibodies yet, by targeting potentially survival pathways, and the BCL pathway targeting is bearing fruit. I didn't have time to talk about it today in the main talk, but perhaps we could discuss during the discussion. And that has shown proof of principle in the relapse setting and now being incorporated potentially into frontline trials that we're planning here in the United States. And with that, I'd like to say thank you. Again, thank you so much to the organizers for inviting me, and thank you for your patience with my technical inabilities. And I'd like to thank my colleagues at the University of Chicago and around the country in the cooperative group setting who are listed here on this slide. Thank you so much.